everybody. Thank you for joining us. My name is Parth, and this is going to be our first ever video public health one-on-one sort of a session. Till now, we were mainly writing blogs, but now, thanks to Dr. Anand from Coimbatore, a total stranger who just reached out to me and offered me help, and he has sort of gifted us this Zoom account to sort of increase our outreach. And today we have Dr. Pranab with us. Dr. Pranab did his MBBS from Kolkata, went on to do his MD in community medicine from Delhi. Currently, he's working in Johns Hopkins University, doing his PhD. Welcome, Dr. Pranab. Thanks a lot for joining us. And
thank you.
So,
just one quick thing. Just call me Pranab. No need for Dr. Pranab.
Okay, sure. So, Pranab, thanks a lot for joining us. And I'll just tell you a bit about what Nivārana is, because this is going to be our first ever video which will go up on the blog and even the YouTube channel. So this started off in July as just a place where I wanted to take out my frustration about public health in the country. Sort of at the same time talk about, what really health is. So it started off as a blog, but now soon with the help of other people, a few strangers I've never met in my life who have now become a team. And this has sort of grown into a platform where we are increasing awareness related to public health and social issues. We are trying to bring public health enthusiasts together to collaborate on projects. So this is sort of where we are right now. A section of this, which is called Public Health One-on-One, is what we are doing right now, which is where we talk to people who have worked a lot in a particular area, in a particular topic, and we sort of discuss important health issues with them. So this is what today's session is all about. So I just want to start off with asking you, I have given a brief introduction about you. Why don't we hear something about you in your own words?
Sure. I did my MBBS from Medical College, Kolkata. I am from Kolkata, born and brought up there. I did my MD from University College of Medical Sciences, UCMS, in New Delhi, in community medicine. After that, I worked for the Public Health Foundation of India, which is where I cut my teeth in One Health, antimicrobial resistance, emerging infections, a lot of interesting things. After a very productive couple of years at the PHFI, I got an offer to join ICMR, the Indian Council of Medical Research, which took me back home to Kolkata. I joined National Institute of Cholera and Enteric Diseases, where again, I worked for a couple of years, very interesting years. This was the time when I transformed from somebody who was just working on a project to somebody who was writing projects. And it was my first brush writing proposals and, trying to raise monies. Then just before the pandemic happened, I was transferred to New Delhi to start working on this really exciting new platform that ICMR was developing. It was called the Translational Global Health Policy Research Cell. And we did a lot of stuff in a few months, but then the pandemic hit and everything went topsy-turvy, which was, again, another very interesting phase in my life. I was managing the secretariat for the COVID-19 National Task Force, which was in and of itself, an amazing lesson in seeing how policies move, how evidence shapes our decisions, and what discussions go on behind closed doors that shape the papers that we read or the programs that we are made to mug up during our MD community medicine trainings. So it was like being a fly on the wall to some really, really interesting processes in motion. About a year into the pandemic, I joined my PhD training at Johns Hopkins. I'm currently towards the beginning of my third year, midway through my training. I work in the Department of International Health, and I will be now that the pandemic is starting to settle down a little bit, I'll be going back to working on AMR, antimicrobial resistance, that is, and One Health and related stuff. So yeah, that's a little bit about me.
That's really interesting. You have been sort of in very major institutes in the country, starting from Kolkata, one of the oldest institutes in Kolkata. You have done your MBBS from, going to Delhi.
Hey, it's not the oldest institute in Kolkata. It's the oldest
country.
in Asia. In Asia, not even the
In
country.
Asia. Yeah, sorry. In Asia. So you have worked in huge institutes, and I'm sure your experience is immense. Which is what brings me to the next question. Why this profession? Why become a doctor?
Why become a doctor is it's about 20 years too late to ask that question. Depends on the tone. Why become a doctor? Or why become a doctor? But jokes aside, I was always into biology and liked the way the physiology worked, and I think it was a natural transition. Because back when I was doing high school, we didn't really have a lot of um, sensitization to the other options that one could do. And for those who like mathematics, doing engineering was a natural transition. And for those who like biology, trying to go into medicine was a natural option. But there were two things that really sort of also pushed me towards a career in like trying to be an MBBS. One was that I went to a school where I was brought up basically by monks, and they always talked about service to humanity, it being the highest form of any religion that one can adhere to. And it felt that being a doctor was the easiest way to do that. A couple of things, from academic apathy to biological biases and spiritual side effects, came together to push me towards this. Would I have done the same career trajectory had I been in a more liberal environment where I would have options to do, I don't know, something else? I'm not sure. Counterfactuals are hard to wrap your brains around. But for better or for worse, that's the career I chose. And I think if I were to go over and do it all over again, I'd do the same thing.
Yeah.
So, yeah.
No, that's pretty interesting. You talk about how your exposure has been, while you were growing up, and again, it comes down to service to humanity ultimately, which sort of led you into this profession. So you have moved on from sort of preventive medicine, community medicine to public health. And my next question is going to be, what do you think is the most significant or the biggest public health problem which we are facing globally and even in India?
So I don't think there is one big public health problem. I mean, if you want one big public health problem, that's probably good quality healthcare for all, preventive and curative. But then again, that's like more of a systems problem. So if you're looking at a health related answer, maybe my pitch would be emerging infections and antimicrobial resistance. Although more people die of non-communicable diseases now, I think the problem with emerging infections or AMR is that we don't have valid solutions for them. Whereas for the non-communicable diseases, there's a lot of, the pipeline is strong on that one for products, interventions, medications. And there's this personal bias, obviously, for infectious diseases, because I kind of am an ID nerd. So yeah, that is also there. So, yeah.
Yeah, so
these
like
are
you
my
said, multiple
not
problems.
very specific thoughts.
Sorry?
These are my not very specific thoughts on what
Okay. No, but like you rightly said, we don't have one issue to deal with. And even India, globally, we are dealing with multiple issues. But the one thing which sort of is emerging right now is antimicrobial resistance. And even though more people die of NCDs, what I've noticed is, there's always an overlap. There is some sort of you're more prone to infections when you have an NCD, and sort of that coupled with antimicrobial resistance is like a death sentence in most of the times. And like you rightly said, we don't have realistic answers to these problems. So according to you, what do you think, how serious is this problem of antimicrobial resistance? Like, where are we headed?
So yeah, it's pretty bad. If we look at the 2019 paper in Lancet on the burden of antimicrobial resistance, they attribute almost 1.3 million deaths only in 2019 directly caused by antimicrobial resistant organisms, and almost 5 million deaths associated with AMR. So those are just for bacterial pathogens. That's not counting for the other kinds of drug resistance or other pathogens, other microbes. It's just bacterial AMR. And these are pretty big numbers considering that that's just 1 year's toll. The other problem is that AMR is a naturally emerging phenomenon. Like when Sir Alexander Fleming spoke about, gave his, lecture, Nobel acceptance lecture in 1945. He actually foreshadowed the problem of drug resistance because he found that irrational use of the drugs makes for resistant organisms. So it's not something which we don't know. It's like something inevitable. So we all have to sort of control its emergence, but at the same time, figure out ways to make our things last. The big threat here is that a lot of things depend on antimicrobials working well. Surgery, for instance, surgical site infections, post-surgery prophylactics with antibiotics, cancer care. More and more people are surviving immunodepressing conditions like being on chemotherapy or having immune deficiency diseases. And antimicrobials are critical for their well-being and health and survival. So in a post-antibiotic era where we don't have any effective antimicrobials left or any effective antibiotics left, these people's survival will be threatened. So it's not just a whole sort of a problem, but it also covers specific risk groups, some being affected more than others. So yeah.
Yeah, like 1.3 million deaths is like, it's huge. And then when you extrapolate it, then we this is even like, like you're saying, it's only bacterial. We don't even know viral, fungal, protozoal. We don't even know what's happening. And like you rightly said, cancer and surgery. Like cancer is going to take over the world next. It'll soon take over heart diseases, be the leading cause of death, and especially those patients. It'll become like diabetes and hypertension. Basically, people will be just walking around with cancer, getting chemotherapies, and that's where antimicrobials become very crucial. So like we're talking, it's a very huge issue, but who do you think is responsible in the end? Why is this happening? Why does antimicrobial resistance happen in the first place?
So talking from a very layperson's perspective, the first thing is that some people believe if you take antimicrobials, you become resistant to those drugs and those drugs don't work on you as a human being. That's not how it works. The bugs become resistant to the drugs. So when the bug infects you, if you take that drug, it doesn't kill off that bug anymore. So that's the problem. And then the disease continues. So why does it emerge? So basically, it emerges under pressure of evolution. Bacteria evolve at a much faster rate than we do because of their quick generation time. And if we put enough evolutionary pressure on it in terms of antibiotics, we see that kills of 99.9% germs, all Savlon, I don't want to name brands, and on the advertisements of all the antiseptics and biocides and everything. So what happens with the rest of the 0.01% bugs? Like they are not killed off, they survive, they become resistant, and they thrive. So it's like survival of the fittest. So we are putting pressure on the bugs, selecting the fittest amongst them, which turns out to be resistant to the drugs. And that's how antibiotic resistance emerges. The big problem is that if there's horizontal gene transfer, HGT, which is also a recipe for disaster, because that means that one bug becoming resistant to a drug, which has a genetic imprint, can get transmitted to a different pathogen, different bug. And then those new bugs become resistant to the drug. So it's not one country's problem. It's not one community's problem. AMR somewhere is AMR everywhere. So that's why WHO has called protecting against antimicrobial resistance together to be the term called for this year's World Antimicrobial Week, which is interestingly enough right now. Yeah.
Yeah, so in the middle of this sort of antimicrobial resistance week, we are trying to spread awareness. And like you rightly said, it's not a problem of one country or one state or one location. It's just the world's problem. And it's scary because, ultimately it's just that one bug which remains, which is sort of multiplying and even spreading to the bugs which are not antimicrobial resistant. So, like, why is this happening ultimately? Like, who is responsible? Like, so if we don't give antibiotics, we don't kill the bugs, then anyway we'll die of the disease. So what is happening?
Yeah. So that's a very difficult question to answer because who's to blame is not the right question, in my opinion. The question is, what can be done? For instance, a lot of antimicrobial use happens in non-therapeutic settings. In human health, in animal health, in plants. Antifungals have been used for raising crops for decades. Azoles have been very commonly used in as biocides in plants. So there's the risk of antifungal resistance. Although there's no very strong evidence linking agricultural use to the emergence of antifungal resistance, the emergence of antifungal resistant organisms like Candida auris, that's major concern. So that's number one. A second thing is that there are lots of behavioral traits. For example, you have a little sore throat, you walk up to the pharmacist, you ask for a couple of days of antibiotics, you don't take the full course, you start feeling better after a day or two and you stop. Perhaps you didn't need the antibiotics. Most likely your sore throat was caused by a virus, which doesn't get killed by an antibiotic. In the animal health sector, there's this thing called antibiotic use for growth promotion, which means animals which are raised for food production purposes are fed antibiotics so that they don't fall sick and they gain weight faster and they grow faster. And all that makes things worse. Every unit of antibiotics every unit of avoidable use of antibiotic that we don't avoid using takes us that much closer to AMR organisms. I'm basically oversimplifying the problem statement here, but the premise is antibiotic resistance or antimicrobial resistance is a very natural and inevitable outcome. What we have to do is we have to slow it on the emergent side, and on the side of research and development, figure out new drugs, new mechanisms, new products, so that there's a new set of tools to counter antimicrobial resistance with. But the problem is, you make a new drug today, 5 or 10 years down the line, that drug will start showing, and bugs will start showing resistance to that drug. So where does that leave you? As a pharmaceutical industry, you made a new drug, you put in billions of dollars, spend years, and then in 10 years before you have recouped, they're not doing it for charity, they're doing it for profit. So before you've recouped your investment and you've made a hefty profit, which pays all the millions of dollars they pay in, their bosses, they're not interested in making those drugs because the return on investment is low, the risk is very high, the externalities, dwarf. But if they can make a new statin, if they can make a new anti-diabetic, a new flozin, there's no resistance to that. And people take that for the rest of their lives. Whereas if you get an infection, you'll probably take it for 10 days. Also, new antibiotics are often clubbed. So there's this AWARE classification by WHO, in which the axis is the commonest drugs, And reserve is the newer drugs or third line drugs. So it might be that your product gets put on shelves as a reserve drug because it's so good that people don't want resistance to emerge against it. And then where's your market? Who do you sell it to? So lots of things are being done. There are policy options. UK has introduced a subscription model like Netflix for antibiotics. Yeah, there are pros and cons of it all. That's for a, that's a longer discussion for some other day.
Yeah.
But a lot of things are being tried out, but it's not just a third person's responsibility. It's not just the doctor's responsibility. It's not just the government's responsibility. It's also our responsibility as consumers. It is time that we stopped pressuring the physician for giving an azithromycin or a coamoxiclav, but rather question them. Oh, you gave me an antibiotic. What do you think this will treat? What is your rationale? And figure out that, you are getting treated for the right thing with the right meds. And on the animal health side, more judicious use of antibiotics, alternates to antibiotics, like having biosecure farms, having animals being raised in a less infection-prone environment. Easier said than done, for sure. None of the solutions are foolproof, bulletproof. It's just we have to layer up against the emergence and hope that multiple layers of protection eventually works like a Kevlar vest and saves us from the bullet of AMR.
No, like
Very
you
violent.
it's you can't blame anybody. It's the problem is it's not even like multi-level. I feel it's multi-dimension, like where you can't point fingers, you can't say anything because it's like you said, it's animal use, it's human use, it's
environmental use.
Environmental use.
That's why it's such a great One Health problem.
Yeah.
AMR is the quintessential One Health problem. We hear the word One Health being bandied about very, very commonly nowadays because it's the term that has come into the common parlance in the aftermath of the COVID pandemic. And that's exactly what One Health does. It looks at challenges emerging at the interface of human, animal, and environment interactions. And AMR is a very good example of such a problem. So yeah, that's also one area that I'm interested in. And when you talk about multi-sectoral, multidisciplinary problems, AMR is probably, again, a very good example of it. Because suppose there's this recent study that came out which showed that people with pathogenic drug-resistant E. coli, basically UTIs with drug-resistant E. coli's, were getting tracked to retail meats with the same genetic imprint. So extraintestinal infections with drug-resistant organisms. We tend to think of, if it's in the food, it's just going to cause foodborne diseases like gastrointestinal diseases, diarrheal diseases, but apparently not. There's so much more we don't know. So yeah, we don't know how the environment links us to everything else and the water that we're drinking, the soil that we are coming in contact with. We don't know how the microbiome in each of these, microbiome is basically the whole set of microbes within a particular area, how they're interacting, how they're modifying our non-communicable disease risks. So it's a lot of new, interesting, emerging knowledge in this field. So yeah, I'm sorry, I'll get off my soapbox now.
No, like you rightly said, there are so many problems. Like I was writing things down to say, but I've already filled a page, and like it starts right off from animal use, and like you just mentioned, environmental. We don't know enough is another very huge problem. Research funding being a problem because ultimately, who's making antibiotics if it's not giving profit? And again, just because if it's so good, obviously the WHO will put them on reserve drug, and again, there's no profit. So ultimately, it comes down to which drug is making the most money, and sadly, antibiotics are not. And like you pointed out, there are roles for different kind of people. Like clinicians have to be careful at prescribing antibiotics. General public has to sort of not ask for too many antibiotics for simple things like a sore throat, which could be a viral infection and not a bacterial infection. And public health experts like you need to sort of do their research, figure out what's happening where, and sort of see which policy works where and address those issues in that sense. And thanks a lot for just, sort of summarizing this whole complex topic of antimicrobial resistance in such simple terms. Now, I just want to go on a personal note from here. So, you are sort of doing your PhD in antimicrobial resistance. And so, where do you think, where are you headed from here? Are you coming back to India, helping us solve antimicrobial resistance, or so what's the plan from here?
So I'm planning to work on my thesis in India. So in the short term, for sure, yes. And I don't know how things work out in the long term because I do have a picture of what I want to do in 5, 10 years time. But who knew 3 years ago that there would be this pandemic that would turn the whole world upside down and change the way we do everything? So I think there's a lot of the, error intervals for making decisions long term has become very large. Uncertainties are very high, which makes it a little difficult to make prescriptive, one-line plans for, oh, I want to do this in 5 years' time. But for the next few years, 2 to 3 years, for sure, I'm working in India. I'm working on AMR, and hopefully, I'm working on a One Health context as well. The problem is, One Health is it's easy to say, let's do One Health. It's actually hard to do it. Mm-hmm. It's so hard to do it that the quadripartite, that is the WHO, World Animal Health Organization, Food and Agriculture Organization, and United Nations Environmental Program, the four big stakeholders in One Health. The quadripartite got formed in April of this year. Before that, it was just WHO, World Animal Health Organization, and Food and Agriculture Organization. So it was not really a complete One Health, setup. So that's how difficult it is, that if it takes the UN agencies so long and they have to think so hard to get, collaborative, how much harder would it be to work at the local levels in settings where vertical systems are in place? The animal department works in their own way. The health department works in their own way. The environmental department works in their own way. So yeah, as I'm planning my thesis work in India, I'm also coming face to face with these really, really virtually unanswerable, pragmatic questions. But then again, that's the joy of doing research. Finding questions and difficult questions to answer is part of the whole process.
Yeah.
So a non-answer to your question about what I want to do, but yeah.
No, I hope you come back to India and sort of solve this issue, because India definitely needs a lot of people like you.
I don't think I have the hubris to say that I can solve anything. If one can even move the ticker tape an inch forward, I would be, I don't think I have the solution to anything, but yeah, moving the agenda forward.
Yeah. So you've been working with infectious diseases for quite some time now. And in your past experience so far, what has been your sort of the one thing that you look back to whenever you're feeling low and you think about it, that, I did this, and you feel good about it? Well, what has been so far your most memorable achievement in this field?
Oh, that's a difficult question to answer, because I've been trying to sort of dig in and find motivation for myself in the last few weeks. The first thing is that I have been told that one has to be kind to their own selves at this point, because we have lived through so much trauma, having gone through the pandemic, having gone through so much death, despair, around the world. That's one thing. The second thing is, I don't think I have done anything that actually counts for much in the long term. But I look back, and when I look back, I actually find moments where where I've interacted with people that stand out as, reminders of, it's not all dark and bleak and stormy nights. There are, moments of sunshine and glory as well. For instance, when I was working in Kolkata, walking around the urban, slum areas, figuring out what should be the next step in getting the clinical trial implemented, and worrying, oh my God, people are not going to want to be part of this study. And then finding 30 mothers demanding that, no, I want to be part of your study because it was so good talking to you. And then, then realizing that one group discussion we had in the community where I sat on the floor talking to the folks and trying to realize what their perspectives were, what would make it easier for them to be a part of the study, telling them about the study, being very open about the fact that this was in a research mode and everything. And then finding them, I was like, oh, this is not going to work out because I think I've been too honest with everybody. And then we're finding out that not just the 20 people that I talked to, but 10 of their friends have turned up and be like,
Yeah.
Or, sitting in the infectious disease hospital clinic wondering, where is this pandemic taking us? And then figuring out somebody walking by with a mask and just looking at us and saying, thank you for doing what you do. And just, unsought acknowledgement of the whole boatload of crap that we have to go through in our careers. Sometimes that makes it so much more fun to do what you're doing. The one big problem in public health is that we don't have a lot of instant gratification. If you're working in the ER or if you're working as a surgeon, there's this lump, you cut it out, the patient gets better. Or there's this patient that rolls in with a, hypoglycemia, you push some 25D and they jump up. Or, you have that instant gratification of seeing your efforts yielding results in a meaningful way. Public health doesn't work like that. One real amazing thing that happened was when we did that convalescent plasma trial in India. Even then, it took like a few months for the policies to change. But that's a really short time for policy change to happen. But even then, it's like already in the past. So, the human connect sometimes may become tenuous, particularly when you're in a pandemic setting, not being able to connect with a wide range of stakeholders, almost always working in small groups. So I think I draw more energy, or what little energy I can draw nowadays, from these human interactions rather than from anything that I have done, because honestly, I've not done anything really.
No, you are too humble to say that, actually. I know you have done a lot. And but that's what you just said reminds me of the longest study on happiness, the 75-year-old long study, which I think Howard did to find out what makes people happy. And ultimately they found out that, it's the relationships that ultimately make somebody happy. So yeah, even like if you ask me, I remember that coffee that was brought to me at 2 a.m. by some patient relative, who just said, "Doctor, you've been awake full night. Why don't you have a coffee?" So yeah, things like that is what I eventually remember. I don't remember much of what I studied or those lectures, but this is what ultimately
stays with you, right? Long after you've forgotten what you've done to a patient or done in a study, what you actually remember is how you felt while you were doing that, or what people felt while they were, involved with your work.
Yeah, definitely.
That's maybe a very shallow way of looking at things. I'm not super philosophically, elevated. So yeah.
Like again, you said, I remember having this conversation with you before as well. Why public health? You told me there won't be any instant gratification. You'll be sitting with papers for months and years, and you have to find something that sort of makes you happy. And I feel this project Nivārana is something like that for me. Talking to people like you, it sort of gives me those. It sort of gives me, besides giving me a lot of knowledge on the topic, it also gives me these moments that I'm sure I'll remember. last question for you. Actually, the second last question for you. Is there anybody else, who sort of inspires you, keeps you going? Anybody, if you could point out one or maybe more people you look up to in this field of public health?
Oh my God. I mean, we're going to be here all day because when I say I literally stand on shoulders of giants, I literally do, because science is like the slow incremental way we find knowledge, sharpen knowledge, make it better. And public health more so, because on one side, there's the knowledge generation, and then on the other side, there's the knowledge implementation. So just doing the clinical trial doesn't mean anything unless you bring the product to market, unless you get the product in people's hands. So yeah, I mean, I have so many people I look up to, particularly during times of moral crises, A recent hero has been Paul Farmer, a recent hero in the sense that I've been talking about him with a few people of late. And I think some of his thoughts have really hit me very hard. The way he talks about global health not being health in a poor African country or South Asian country, but global health is everywhere. Global health is in the food deserts of Baltimore. Global health is in road traffic accidents in Europe. Global health is in racial disparities and minority abuses all over the world. It's not just a poor countries or low middle income countries imperative to be the recipients of global health. So I feel like Paul Farmer's works and words have expanded my horizon of thinking. He gave a very informal chat, talk, lecture a couple of years ago, when we had just joined Hopkins, and the amount of energy he brought to his work, the amount of passion, strength, and strength of conviction he brought to his work, that was just amazing. So I've never stopped reading his works, and whenever I feel a little low or down, I turn to Mountains Beyond Mountains, which is always a good prescription for putting me right back up. I keep gifting that book to everybody I know. So yeah, that's one person that I have been thinking about a lot of late. Another person back from a little while back that I've always admired is William Osler. So it was really, really humbling to be able to stand in the, in Hopkins, in the hallways that Osler walked in, and, how the hell did I get here? So that has been a constant reminder of the fortune and grace I've been gifted with. I keep the quotable Osler very close to me. It's a book that I love reading. I am a self-professed Oslerophile, and although Osler did a lot of clinical work, most of his work is in clinical medicine. He is basically the father of the residency training system, so to say. But I find that the way he approached teaching and capacity building to be very inspiring. That's another hero I often look back to. I love Oliver Sacks for the way he writes and feels about his people, his patients. I have been reading his works, and even though I don't understand a lot of neurology, I marvel at how simple he makes it to understand complicated topics. And I hope that, even if one can become a 10th of that, to bring science to the people, that would be amazing. Because we are doing science with the people's money. Our salaries or our research monies are coming in from the taxes people pay. So the knowledge should go back to them, and not in the form of a paper in NEJM or BMJ or IJMR, but in the form of something that everybody can understand as how it relates to their lives, not as an abstract odds ratio of 3.5, but in a way that people understand. Oh, hell, even most physicians don't understand odds ratios that well. My grasp on odds ratios is tenuous at best. So if you speak in those jargonized terms, I always think of how would Oliver Sacks speak about this? And then I fail to do that. So I'm still working on that, which is where writing for blogs and all these things came in. And which is why I really appreciate the fact that you're doing with what you're doing with Nivārana, trying to break science down without dumbing it down, bringing the knowledge to the people in a way that matters and connects with their lives. Vaccines, for example, or AMR, they connect. You take a vaccine, you prevent an infectious disease, you don't take the antibiotics, you prevent your AMR emergence. So bringing these small things, which we take for granted in academia, to the light for people is of utmost importance. So, I have a lot of heroes that I look up to, and I constantly feel that, oh my God, what can I learn from them, and what can I do to be a better public health advocate for the people, not for the paper, not for the project, but for what it would mean to somebody living in West Bengal or living in Delhi or living in India, and how it would affect their decision-making processes. So yeah, that's one of the things. So I have a lot of heroes, and I'm so fortunate to be at Hopkins because you literally knock on the doors and walk into the rooms, and you walk into the world's leading expert on literally any topic, and to have that kind of access to the expertise and leadership is just mind-boggling. So I have a lot of real world, real life heroes as well. It's not like just Osler and Paul Farmer or Oliver Sacks, big names. It's just there's a lot of heroes in my everyday work that I meet, that I draw inspiration from. I wish I had more time to, because in the last couple of years I have gone back to being a student, which has taken me away from the field work, because I think what I like doing best is seeing how I can synthesize whatever I'm reading or learning about from the thoughts of these great people and apply it in my everyday work on the ground in the field. So I'm very much a shoe leather epidemiologist at heart, and not being able to do that shoe leather epidemiology has been eating away a little bit at my soul. So yeah. Oh, and one more thing, I'm a huge fan of, I know every organization comes with a lot of problems. Okay, stop me whenever I get too long,
No, please continue. That's all right. No, please continue.
Yeah. So another organization that I really admire is Doctors Without Borders, Médecins Sans Frontières. I know there's been a lot of problems with them. They've had white saviorism, anti-decolonization allegations. Lots of stuff have been put up with them. Every organization has their problems. I'm not papering over those things. But I really admire what they stand for, because they bring succor and relief to people who need it the most. And so they're also one of my heroes. I love reading this book by James Orbinski, An Imperfect Offering, which is a very, very frank look into the way humanitarian aid, health, MSF, all these agencies work in that space. And the honesty of it and the sheer, joy of working in that space that comes out of being able to, not just joy, like the pain of working in that painful situation as well. All these factors, they also make me think like they're one of my heroes. It's hard to say it's an organization, it's not a person. Yeah.
You have a lot of giants as your heroes. Paul Farmer even being one of my sort of person I look up to. And, that's how we've been making friends these days. I asked him to watch the documentary called Bending the Arc.
Yeah.
And if people don't cry after watching it, I can't be friends with them. That's
you're not friends with me. You're not friends with me. I was heartbroken. We have so many friends that work with PIH, and one of our friends just texted us in the morning, and they said, Paul is no more. And I was like simply heartbroken. I've never met this person in person, you know. Uh, he's like he's his passing away should not mean that much to me. But both Bhavna, my much better half, and me, we felt so crushed that day. Like it was as if we had lost a dear friend, a mentor. And I think there were millions of people around the tens of millions of people around the world who felt that way. So yeah, that is a personality, that is a person leaving generational impact, because there are going to be generations of physicians, public health people who will come, you know, admiring him and thinking about the work he's done, thinking about the difference he's made. I think that's the kind of person I would aspire to be if
same.
I'm allowed some narcissism.
Yeah, I love how he's a mixture of knowledge, humor, and like he has a bit of everything which is actually needed in a person, which is something I really admire.
Something he says is that it has theological roots apparently, but I'm not aware of it. Others say that this is grounded in Lords of the Ring lore. Something that he has said is that we are fighting the long defeat, you know, all these big problems that we are trying to solve, we are likely not going to be solving them all in our lifetime. So it's all fated to result in a final big failure or defeats. But what counts is you don't abandon the side of the, you know, people who are facing this defeat. You still struggle on, push through, and just keep at it, I guess. So I found that incredibly insightful, because more often than not in public health work, like aside from not having instant gratification, we don't see big successes, big wins. We should take the small wins when we can, but not get sort of discouraged by the lack of big wins, because every step forward, if this drug doesn't work or if this therapy doesn't work, that's also knowledge. We save people's lives by telling them, hey, don't do this, do something else. I don't know what you should do, but you shouldn't do this. This doesn't work. So yeah,
Yeah,
I
that's
think if
that's a sort
defeat
of
has,
beauty in science, you don't fail in science. Everything that you do is you're learning something or the other. And just to end with one last question, I think I've kept you on for too long. Just one thing, one last question I'm going to ask you is, what is going to be your advice for people who are planning to become, say, public health experts, or even
let
venture
me
into
first
alien
become a
work?
public health expert myself before I start giving out advice.
Oh, yeah, okay, public health professional. Okay, I won't use the term expert then.
I mean, I don't have advice to give, because I literally don't see. When we talked about it, I mean, we had very frank conversations when you were choosing to come into community medicine, right? Um, I felt that knowing the limitations of our training and our profession is one important thing, not over expecting or having unreasonable expectations from the training process. That's the first thing, because a lot of people get into community medicine with unreasonable expectations, and then those expectations are dashed, and then they trash the whole field of public health and move on to something else. That's not great. So know about what you're getting into, and see, everybody has their proclivities. Like you might be somebody who likes to sit in a clinic and do patient care. Public health career may not be the best thing for you then, because you will carry that clinical baggage around with you all your life. Not to say that you can't be a clinician. Public health clinicians are a real deal. And when I was doing the clinical trials, I had to like figure out what all I had to do, because I was the first point of contact. So it's different. It's different from hospital-based medicine or clinic-based medicine, the way it's done. So you need to understand what you're getting into as an early career professional, what your training gives you. And you need to feel happy doing the work. It's not a lot of glamorous work. For instance, when we were doing the field testing of the first batch of rapid diagnostic test kits for COVID-19 way back when, it seems like a lifetime ago now. It was not glorious work. It was wearing those spacesuits in the Delhi heat and going into the ICUs or isolation units, taking samples, doing tests, and coming back dehydrated in 3 hours. And there would be literally pools of sweat, collecting at the bottom of my foot because I was sweating so badly inside that suffocating suit, which we don't even need. But it's not glorious work. It's not glamorous work. I didn't get acknowledged for it. It's not paper that's published anywhere. It's not written up by any journalist. But it was very important work. ICMR established some really, really important findings very early on that helped guide figuring out diagnostic development. So a lot of the work will happen behind the scenes, and you have to find succor and inspiration from the fact that you worked with the people to help their lives or help solve problems that, that you'll never be the one person solving the crisis of AMR or solving the crisis of non-communicable diseases or cancers. This will come through only with thousands and thousands of people working together in concert, and you will play a very tiny small part, if you're lucky, a very small role in pushing the agenda forward, and that you should be okay with that. Because these big problems, they get solved by big efforts, and big efforts come from a wide number of people working together. So having the humility to address the fact that you don't have all the answers and you're likely to fail, and you will probably need a healthy dose of motivation to keep you going. All these things are important. But at the end of the day, if you feel happy working in the field, happy working with the people, if you feel you're interested in crunching numbers and sitting with transcripts and figuring out what's going on in data, if you have interest in defining a problem in a way that nobody else has thought about, or redefining priorities within which to look for research angles in, or figuring out the best way to solve an entrenched problem, or bringing in new tools from different fields like economics, AI, technology to solve health problems. Public health is the best thing you can do, because of all the things that we can do as physicians, public health gives us the most multidisciplinary kind of career pathways. You can be a health economist, you can be a researcher, you can be a statistician. If you love numbers, if you love technology, you can be a digital health professional. You can write policies if you are good with, interpretation and foresight. You can do a lot of things. And that's not to say you can't do these things if you don't choose public health as a career. But yeah, I mean, for somebody like me who gets bored with doing one thing very easily and wants to do 500 different things and has 500 different interests pulling him in 500 different directions every minute, public health is the way to go. That can be a big drain as well, because sometimes I feel, oh my God, I'm so tired, I don't want to do anything. But yeah.
Yeah, actually, this is what convinced me to do, sort of community medicine, and then eventually move into public health. Is the freedom I get, just not just with work, but even like there is a sort of a work-life balance, like which you can maintain. But like you said, like we are fighting a losing battle. But I want to end on a positive note, so I am not going to end on that note. Everything we just said, I think I can summarize it in one quote, which is one of my favorite quotes by Mother Teresa, in which he said, I cannot change the world, but I can cast a stone across the waters and create many ripples. And I think that's what is needed, like we have to do our bit. And
Yeah.
we might not solve the problem, but whatever like small bit we did might help anybody else in the future, or maybe thousands of years later, to solve that problem.
Yeah. It's like that story of the starfish on the beach, you know? So there was this one guy walking along the beach, and there were like thousands and thousands of starfish lying on the beach, stranded in the sand. And this guy was picking them up one by one and throwing them back into the sea. Another person comes along and they're like, hey, what are you doing? You'll never get to all of them. Like, what difference do you think you'll make? There's like millions of these lying all over the beach. The other person just picks up a starfish, puts it in the water, and like then says, yeah, I know, but I made a world of difference to this one.
Yeah.
So I guess I guess it's all about the way you see things and think things through. Even I'm happy being a small part of the solution, even if it means that, I work in a little bit of obscurity. I don't have instant gratification. As long as I can have fun in the work I'm doing and think through complex problems, having interesting solutions, I'm happy. We are all playing our part, whether clinical or not,
Definitely.
public health. And yeah, I'm grateful to be part of the whole show.
Yeah, we hope together we can eventually make life better for at least some people, if not everybody.
Yeah,
I think that's what matters in the end.
for
So
sure.
I just gotta let you go now. I think it's been already been maybe, I think, 1.5 hours or something. So
Oh my God, ready? You should have
yeah.
asked me to get off the soapbox.
Huh?
You could have like stopped me. Stop.
No, it was
Word.
really interesting. This is what I think eventually the stories that make the difference, and it's not the numbers. The stories, the COVID stories, the stories from your trials that you told, eventually that's what sort of makes you believe that, this is what uh, we're in the right field, eventually that's what makes the difference, I feel. So thanks a lot for joining us today, and wish you all the best. Huh?
Thank you. Thanks for having me on
Yeah,
as
I
the
wish you,
first one conversation.
yeah, definitely. This like the first ever Nivārana video, and you're featuring on it. So congrats to you. And wish you all the best. I hope you come to India soon, and I think we can finally meet in person. That's something I'm
Yeah,
looking forward to.
same here.
Okay, thanks a lot for joining us. Have a good day.